And you can begin.
Thank you, Stephen. So, yes, so for those of you who don't know me, my name is Susan Dent. I'm a medical oncologist here at Duke and Associate Director for Breast Cancer Clinical Research and Co-Director of the Duke Cardio-Oncology Program. Jessica Reagan is a fourth-year internal medicine resident student who has been working with me and certainly in the cardio-oncology clinic here. And unfortunately, she's unable to give her presentation today. So I will be giving her presentation, but I do give credit to her for putting together the presentation, and I will do my best to present her slides with fairly short notice. So today, what we're going to do is talk about cases across the spectrum of cardio-oncology care. And to just sort of step back and look at a very high level, we recognize that our cancer patients have potentially cardiovascular issues throughout the continuum of their cancer journey. So we clearly see patients in our practices that present to us with a new diagnosis of cancer that may have pre-existing cardiovascular disease. There are those individuals who develop cardiovascular toxicity while on their cancer therapy. And then, of course, there's a growing cancer survivorship population who are at risk of developing late cardiovascular complications. And so Jessica had put together 3 cases that we're seeing here at Duke in the Cardio-Oncology Clinic to really highlight these 3 time points in what I would call the cancer care journey. So I'm going to start with the first case, and this is actually a patient of mine, and I'm very open for those on the call. If you have questions or comments, you can certainly chime in at any time as we go through these cases. So this first case is a 42-year-old woman with a non-ischemic cardiomyopathy that was actually diagnosed back in 2011. At the time, she was 34 years of age. And the cardiomyopathy was felt to be due to an H1N1 induced viral cardiomyopathy, although it did occur during her second pregnancy. So a peripartum cardiomyopathy was also considered. You can see there her past medical history, which was really fairly benign. She had some exercise-induced asthma. She has a pretty strong history in her family of coronary artery disease, as well as breast cancer, including a maternal aunt diagnosed with breast cancer at the age of 35. At the time of her H1N1 induced cardiomyopathy, echo, as you see there on the right of the slide, showed severe LV dysfunction with an EF of 20%. She had a cath done at that time, which showed normal coronary arteries. So just to remind us, and this is a nice review that was recently published in JACC of the many different causes of a dilated cardiomyopathy. Of course, up to 30% can be idiopathic. However, other causes include inflammatory dilated cardiomyopathy that accounts for about 1/3 of the cases that we see. And there you can see in with the yellow star that viral is certainly a very common cause of this. Autoimmune diseases can also lead to this, as can conditions such as a peripartum cardiomyopathy. So certainly she had a couple of risk factors that placed her at risk for the development of this situation. So she was treated after her diagnosis with metoprolol, losartan, spironolactone, Lasix, and had a ICD placed. 6 months after initiating medical therapy, she had a right heart cath, and you can see her values there. And they did attempt to up-titrate her medications. However, this resulted in symptomatic hypotension. Attempts were made to switch her from losartan to Entresto, but she experienced fatigue and shortness of breath. And so from there, she went to cardiac rehab. Her course, moving forward a few years, she developed SVT in 2017. 2018, she had a hysterectomy due to fibroids and polycystic ovaries. And then in 2019, she noticed a firm mass in her right breast. She had a mammogram done, which showed a close to 2 centimeter breast mass. And on biopsy, this was confirmed to be invasive ductal carcinoma with lobular features. Clinically, it was a stage 1 disease. She did have genetic counseling at that time for her breast cancer with no mutations detected. So she comes to us with this cancer. The oncologist sort of asked, what therapies would you consider for her? So this is what we were thinking. Just to go back a minute, I want to highlight this. This was an ER/PR positive, HER2 positive cancer. And the cardiologist came on board as well. We asked them to be involved. How would you counsel this patient and the oncologist? So you have a young woman with a HER2 positive breast cancer who has a history of a viral cardiomyopathy, who has good coronary arteries, but has persistent compromise due to a previous history of cardiomyopathy. So we did discuss her in a multidisciplinary conference and decided that she should go to surgery first, which she did. She had a lumpectomy and sentinel lymph node dissection, which revealed a 62 millimeter or a T3 invasive ductal carcinoma grade 2. 1 out of 1 sentinel lymph nodes were positive with extranodal extension, and she did have positive resection margins. The receptors were the same. She did have imaging at the time, which showed no evidence of metastatic disease.
Susan?
So now, yes?
Sorry
yes.
to interrupt. This is Dan.
Yes, hi, Dan.
Thank you so much for doing this and presenting this case. I did want to just touch with what you just presented, where you had, you know, the oncologist and the cardiologist, and then you had a multidisciplinary conference and you came up with the plan for surgery first. What was the basic thinking there? Why was that choice made instead of neoadjuvant therapy?
Very good question, Dan. So, you know, sometimes we do consider neoadjuvant therapy in these women, particularly women who have cancers that are over 2 centimeters in size, because that can impact what we do after surgery. So clinically, when she had her diagnostic mammogram, this was felt to be a fairly small lesion at T1C. So that's sort of, you know, for those women with smaller breast cancers, we do sometimes send them to surgery first. The other issue that we discussed at the time of that conversation was, would we get into trouble with neoadjuvant therapy and then have to delay her surgery? And so there were a couple of things that came into play. But definitely you're right. For if her tumor on clinical, you know, diagnostic imaging had been, let's say, 25 millimeters to 30 millimeters, there would have been a stronger push probably for neoadjuvant.
And then what was her current EF?
I'm going to show you that.
Okay, but before you go to that, the other thing that you did is you sent for a genetic profile with Invitae, and actually we had a case presented by Alex and his team just recently where there were some possible variants of unknown significance in relation to cardiomyopathy that were present. And
right.
Invitae actually for free will do cardiomyopathy panels looking for those VUSs. So you know, for example, what is on your Invitae 9 gene panel that you do?
There are, you know, beyond the sort of BRCA1 and BRCA2, and I don't have the whole list in front of me, but they also do, most of them, to be honest with you, are variants of unknown significance. And
for breast cancer.
For breast cancer, sorry, yeah. So I don't, this was specific for breast cancer. We did not do, that's a very good point, Dan. We did not do sort of a cardiomyopathy panel.
Yeah, because you know the thing is, especially with Invitae, they've been really great, at least in our experience. So you could even just call them and ask them to add a cardiomyopathy panel if they've recently done this sample. I think they keep it for a year, but they'll do it for free and just run the cardiomyopathy panel. It probably would be of some interest in this case, I would imagine.
It would, because if you go back to here in this slide that Jessica put together, you can see that, you know, there have been a number of genes, as you said, that have been associated with cardiomyopathy that we could explore. So that's a good point, Dan. I can certainly go back to see if they still have the sample. We could add that. Again, here's a case of, I'm always so focused on the breast cancer genetic mutations, but certainly we can ask. That would be very interesting to do.
Great, thank you. Sorry to interrupt.
No, I actually think this should be an open discussion, and I think that was a very good point you raised about the neoadjuvant treatment. So unfortunately, in her case, what happened is that despite the imaging showing this initially thought to be a small tumor under 2 centimeters, it actually ended up being, at the time of her surgery, a rather large tumor, a T3 tumor with 1 out of 1 sentinel nodes that were involved, with extranodal extension and positive resection margins. So at this time, normally in the course of breast cancer, one would consider going back and doing more surgery to get clear margins and to probably do a full lymph node dissection, right? Because she's got risk of having further lymph node involvement. But we felt that we should not delay her systemic therapy any longer. And so she did have an echo prior to initiation of her treatment. And this is what her echo showed, Dan. I don't have the pictures, but her EF was 35%. She had some mild LVH. And you can see her GLS was minus 12.7. And on the right-hand panel are her medications that she was on at that time. And she really had problems with hypotension. So we really had a hard time really considering up titrating any of these medications. So any comment from the cardiologist sort of today on sort of this treatment plan with all these medications? Yes.
Hi, good morning. This is Patricia Guerrero. So,
hi.
Hi, good morning. So, yeah, fascinating case. What a challenge. Question,
Yes.
in reference to the echo, you're describing that the patient had some left ventricular hypertrophy, but historically she did not have a history of hypertension. So was the hypertrophy further defined, and did she go on to have perhaps a cardiac MRI, either pre-cancer diagnosis as part of their cardiac workup when she developed the cardiomyopathy, or subsequently to determine whether perhaps there was some sort of infiltrative disease?
Good question. I can tell you she did not. I am not aware of her having, she may have in the past. This is all the information I have. In terms of her cancer diagnosis, I do not believe she had a cardiac MR, although, certainly in this case, this might have been a reasonable thing to do given her history.
May I interrupt?
Sure.
This is Kibar Yared from Toronto. So to Patricia's question, it could be just eccentric left ventricular hypertrophy that goes along with an enlarged left ventricle and together with this global hypokinesis that she's seen. It's not necessarily concentric LVH and therefore suggestive of an infiltrative process.
So her ICD was placed when?
At the time of her original diagnosis, Dan.
So in 2011, somewhere around there?
Yep, I believe so.
Hey, Susan, I know you just started getting into the case, so I'll withhold my comments if you're getting to it. Will you comment on the use of spironolactone in a ER-positive breast cancer, or are you aware of the theoretical concern there?
I'll let you comment on that.
So spironolactone is an aldosterone antagonist, but also affects the testosterone axis, and so it can cause increase in estrogen levels, and it's never been fully studied clinically, but theoretically would be contraindicated in an ER-positive patient, and so we usually use a eplerenone instead.
That's a great point.
Yeah, that's a great point. Thank you.
And so her breast cancer was on the left, or where was it?
It was on the...
It's on the right.
Yeah, Jessica.
Well, that's good, because then you don't introduce the whole process of having to deal with the device in the field of radiation or whatever.
Correct.
So at least on that side of things, she's okay.
So this is what she was treated with. So TCHP, which is sort of one of the common regimens used in the treatment of HER2 positive early stage breast cancer, which is docetaxel, carboplatin, trastuzumab, and pertuzumab. It's given every 3 weeks. And this is sort of an interesting thing that's come up, and I wouldn't mind comment on that. Given her cardiac history, pertuzumab was held the first cycle just to see how she did. And, you know, Dan, I know since you're on the line, this is something that you've sometimes proposed, but do people have comments on that? Sort of, you know, given her history, giving both of those agents up front, holding off to see how they do with the Herceptin, and then adding in the pertuzumab. What are people's thoughts?
Well, I don't know what everybody's thoughts are. I know what my thoughts are, but
Go ahead.
And honestly, I've gotten a lot of pushback whenever I brought this up. So just recognize that my thought may not be consistent with everybody else's. But I would argue that this is a risky regimen in this patient because you have moderate to severe LV dysfunction despite best therapy that you can come up with. And I think that the combination of Herceptin and pertuzumab is particularly difficult. And when I've brought this up at different meetings in the past, for example, Anna Barak has said that, you know, we did the study, the Safe Heart study, where I think about 30% or something like that of the patients, I think it was actually 15, the total of 15 patients that were treated with HP who had mild LV dysfunction. And of those 15, 1 dropped out of the study and 2 developed a serious cardiac event. So then you say 2 out of 14 developed cardiac events when they were given the combination of H and P. That I think that that's pretty high. That's a pretty high rate, and but the numbers are really low, so there's not a lot of reporting out there. And so from what we have, you know, the Safe Heart study as an example, we have about 20% of patients will develop worsening cardiac condition with the combination. On the other hand, I think that Herceptin by itself, we have a much longer history of being able to manage those patients. And so my vote in this situation would be, if you want to do TCH, that would be okay, but I would not be in favor of pertuzumab.
Okay,
Interesting.
so I'll take the opposite. The opposite. I mean, I would. The first thing is to sit down with the oncologist and say, I mean, this is a young person, right? What's the best oncologic approach to this? And if they want to do TCHP, I mean, I think that the only thing that you have to do is monitor them closely and follow biomarkers and see them regularly, even in the beginning before each cycle, and make sure that they're okay, and then be proactive if there's a change to cut back, but to give the person the best treatment option if that's what it is.
So Joe, I think, and Dan, we went down the middle between the two of you. So we held her first cycle. We gave her TCH without the P for the first cycle. The plan was for her to have definitive surgery after her TCHP or whatever we gave her. And we also decided that we would closely watch her biomarkers prior to each cycle, and and that would help drive our decision making with regards to her therapy. So you can see there her biomarkers prior to cycle number 1, her proBNP and troponin as such were not bad. However, so she had her first cycle with the TCH minus the pertuzumab, right? So this is what happened. Cycle 2 comes along, and she's up in the chemo unit, and she has chest pain, and she has a carboplatin reaction, fusion reaction. So does anyone want to comment on this ECG?
Cron, the first thing I noticed is she's not paced and her BIV pacing isn't going on, although her QRS is kind of narrow. So she's really not getting.
No, she is pacing.
Yeah, she's
Look
pacing.
at lead one. Look at lead one. You can see that the pacing artifact, she's pacing.
But she's
Actually,
not pacing, she's not pacing in her left ventricle. She's only pacing in her right ventricle.
No, I don't think you can say that. I
Oh,
would
yes,
say
you can. Yes, you can, because you're getting a left bundle pattern, which means it's a right ventricular pacer.
no, you have to know that you have to know the pre-existing pattern, because her QRS could have been 160 milliseconds, and with 5E pacing, it could narrow to 120 or whatever it is right now.
Yeah, but
So
if you're having
I'll
pacing,
say the middle. I think that to Crohn's point, if you have a perfectly paced biventricular pacer, you should have a different pattern in V1, V2, and certainly there's benefit, but it's not optimal.
Okay, well, suffice to say that, you know, she did have this carboplatinum infusion reaction, which you can have with carbo. It doesn't usually happen this early, and usually it happens further down the road with carboplatinum. But we omitted that with her due to her cycle 2 reaction, and then so she was continued on THP. So again, we added in the P. She's now on THP without the carbo, and you know, we actually repeated her pro-BMP and troponin prior to each cycle, and there was only one time throughout her course of 6 cycles that her BMP went up to 209. Prior to that, all of her values were sort of in the 30 to 40 range. And so when she did have her BMP go up to 209, we held the trastuzumab and pertuzumab, and we repeated the echo. And this was the echo at the time that her BMP was at its highest. So any comments there? These are her values.
Yeah, I mean, her EF is probably no substantial change, but her chamber is more dilated and her strain is still pretty significantly reduced. So I wouldn't say that she's tolerating this perfectly by any means.
I mean, it's reassuring that she's as stable as she is. It would be, you know, given the measurements that Dan's pointing out, it's concerning that her LV is more dilated for sure, because that can falsely cause you to think that her EF is similar when her overall systolic function is much worse. But I will put to the group, I guess, to some extent, because this is a very timely case, Susan, in that I just saw a patient in consultation who she's 53, I think. She had initial diagnosis of breast cancer several years ago, and now has metastatic breast cancer. Her last EF was measured over a year ago, and it was like 25%. She's stable and compensated. Oncologist started on palbociclib and then referred her whether she can get anti-HER2. Her initial breast cancer was not HER2 positive, but her metastatic diagnosis was HER2 positive. And so I don't know, you know, in a compensated lady, do we have an absolute cutoff for when we don't use it? She's getting a repeat EF right now to see where she's at, since it's been so long, and she's been on Entresto and some other therapy. But I don't know, to like Dan or Joe, in your experience, if there's a cutoff before you use HER2 therapy, and to Susan, I suspect there's a big difference in advantage to using a HER2 agent than something like palbociclib.
So Josh, I actually take care of somebody that has metastatic breast cancer. She's only in her early 40s and has been treated for years. That's HER2 positive and has cardiomyopathy with an EF in the 30 to 35%. And in the last iteration of how she was going to get treated, we actually used trastuzumab deruxtecan that may have less cardiac toxicity, and that she's tolerated, I think, 3 or 4 cycles so far.
Yeah, I think you could argue lots of different points, but and I've already stated my opinion about the combination of trastuzumab and pertuzumab, but there are a number of trastuzumab versions these days. So
Mhm.
TDM1, for example, appears to be very well tolerated and has even probably less toxicity than trastuzumab alone. So I think that trastuzumab alone or one of these newer versions may be a good choice. But I mean, honestly, this lady's what, you said 42?
She's young.
And
Yep.
you're looking squarely at advanced therapy for heart failure in the absence of her cancer. So if you're thinking about a person like that that's already gotten basically maximal therapy for their heart failure, and they're still with a moderate to severe LV dysfunction, that's a pretty risky population. So, you're about to induce a worsening of her heart failure to lead her to the need for advanced therapy. And I don't know if you really want to go there. So
So the problem is, and I agree with you, Dan, the problem is that, it's also a pretty advanced HER2 positive breast cancer. So.
well, that's what I'm saying. Treating with trastuzumab by itself, we have a long history of that.
Yeah, we do.
So can I just go back to one thing about treatment that I didn't get in early on, but when the cardiogram that you showed, her heart rate was a little bit fast. So you could, I mean, there are some other options. She could get ivabradine to try to get some extra benefits since the pacer is tracking her atrial rate.
Yeah.
So there are.
Yeah, I mean, that's a good suggestion, and I would say ivabradine would be better than adding IMDR.
Yeah, because the reality is that that if she had spasm from carboplatin, that the only time she needs IMDR is if she was getting more carboplatin and that. I mean, I don't think I've ever seen anybody who had chemotherapy-induced spasm that had spasm in the real world in the absence of chemotherapy.
Right. Okay.
Yeah, and I think that IMDR is going to cost you something on the blood pressure. So, you are already, kind of borderline in terms of what you could do medically for her heart failure. So I agree totally with what Joe said there. I think ivabradine would be a good choice here and not IMDR.
Okay.
And I would just make one additional comment in reference to her device. It would be probably appropriate to ask her electrophysiologist just to look at her CRT programming to make sure that she truly is receiving the benefit of BiB pacing. That is something that's non-invasive that can be easily done.
I would do that.
So actually, Dan, I mean, rightly or wrongly, this is what happened. She completed 6 cycles of THP minus the carbo. She went on to, her resection margins were clear. She had radiation on the contralateral side of the pacer or the ICD, and then she was put on ovarian suppression and endocrine therapy because she was ER positive, and she did actually complete a year of HMP, and to date, there's really been no change in her echo or her symptoms or her therapy's been pretty stable. So one could argue that that may not be the best thing if, you take, Dan, from Dan's point of view, should we just have kept her on the Herceptin and not the pertuzumab? Yeah, I can.
I mean, there's no right answer except for the one that you did it and you got away with it. So that's the right answer, right? So,
well, we got away with it for now.
Yeah, but so I would just have 2 questions or comments from that. First would be, how much did pertuzumab really add to this situation? That would be question number one.
Right.
And then in question number two, if her cardiac function had worsened, what would you have done? What would you have done different?
Yeah, so yeah, I definitely think that we would have, you know, either dropped one of them or held it to see if it recovered, Dan. So the one thing that we did do, and I don't have sort of a graph to show you, is I said we measured her pro-BNPs prior to each cycle of treatment throughout her whole course. And with the exception of that one blip where she went up to 200, all her pro-BNPs were pretty consistent in the 30 to 40 range. And so, you know, that combined with her being asymptomatic and consistently, and her echoes being fairly consistent, we felt that it was safe to proceed. But if we'd seen that she was, you know, becoming symptomatic or her markers were going up, I think I would have paused at that point and probably would have said, maybe we should stop here. Now, it also brings up the point, Dan, what's the benefit? Okay, so if you want to look at the studies, Affinity is the study that sort of looked at adding in pertuzumab to trastuzumab, where there was only really a benefit in the node positive population, and she was node positive. The absolute benefit, you're right, is in the sort of the probably 4 to 5% range. However, she's young, and so we know that the risk of recurrence is not only dependent on the pathology and the node positivity, but the length of duration that you're at risk. So that's one comment. So, and then the second comment I'll have for you is, what about a shorter course? What about 6 months? Because we know that there have been studies out there, mainly non-inferiority studies, looking at 12 versus 6 months or 9 weeks versus 12 months. And to date, the majority of those studies have still proposed that 12 months is the standard of care. There was one study out of England that suggested, it was a non-inferiority study that suggested that 6 months was non-inferior to 12. However, it's the only study that's been published. And then I just published a study recently looking at the Ontario data, and it showed that irrespective of why you stopped early, 12 months, 6 months or less than 12 months was inferior in terms of breast cancer outcomes. So I think that the standard of care is still 1 year of the combination therapy in node positive breast cancer. And however, you know, in the context of this patient, one could argue that if you saw throughout the course of her treatment that she was starting to deteriorate from a cardiac standpoint, you could argue to cut that down to, you know, 6 months or wherever you were at that time point. So
No, I think it's a fantastic case, and I'm really glad that you got through it.
So, any other comments? So, I mean, I think it is, again, and it's a no data zone area, right? These patients are individual, and you have to constantly be looking at the pros and cons of continuing, not continuing, but okay.
Yeah, that's a great case, Susan. Thanks for presenting it.
I
have one other case.
Okay.
I think I'll just do.
Oh, go ahead.
Yes,
I have
sorry.
one quick question, and that was with the docetaxel. Actually, I'm seeing a patient today who was only on docetaxel and had a terrific left ventricular dysfunction. She's got a biv pacer also, and it's been 3 years, and she's still having an ejection fraction around 30 or so %. And I just haven't seen docetaxel published as being a marked depressor of cardiac function. She was never on trastuzumab or doxycycline or anything. I mean, so do you have any, doxorubicin, I mean, do you have any, does anybody on the call have any comments about that as a LV depressor, doxetaxel alone?
I would say generally no, and probably there's another reason for the LV dysfunction.
Yeah, well, that's obviously that's got to be in the background because I haven't seen it either, but it's pretty dramatic and the time course was good. But thank you, this is a wonderful case.
I should also highlight to people that, you know, there is data now to support, and speaking to what you said, Dan, for that individuals with the tumors that are less than 2 centimeters in size, that we will often now treat them just with single agent Herceptin and weekly Taxol. So there has been a move to try and de-escalate the intensity of therapy for lower risk cancer. So, but obviously she did not have a low risk breast cancer. Okay, I think I'm just going to,
case.
yeah, I'm going to do one more case because I don't think we'll have time to do 3, but let's do this one. And this is, you guys, this is a lung cancer case, so totally out of my comfort zone, but I'm going to present it anyways. Of a 77-year-old female with a right upper lobe non-small cell lung cancer with lymph node involvement. You can see she had mediastinal and right supraclavicular disease. And here's her past medical history: hypertension on lisinopril, some history in the family of lung cancer and coronary artery disease. And so she had biopsy done, and here she had her molecular pathology showed an EGFR mutation in exon 21. This is apparently present in about 30 to 40% of individuals with non-small cell lung cancer. She had a good ECOG performance status. She had a baseline echo with normal LV function, and her GLS looked quite good at -18. So she was offered this EGFR tyrosine kinase inhibitor, a simertinib single agent, or this combination with another newer agent in a clinical trial. It's a combination. So after cycle 3, day 1, she had mouth sores, MSK pain, some other grade 1 toxicities, rash, and an elevated CPK grade 2. And this was her ECG, cycle 3, day 1. I imagine part of these are also being done for the purposes of the trial. Does anyone have comments on this ECG? Or can comment, I should say?
No.
No? Okay, perfect. So 3 weeks later, she develops a non-productive cough, no fevers or chills, shortness of breath. She's prescribed, I guess I should say in the States is EPAC or azithromycin pack for upper respiratory symptoms. She has an ongoing rash, which is quite common with these drugs. 5 days later, reports a rapid heart rate, dyspnea walking from room to room, poor appetite, nausea, vomiting, and she's taking compazine or Stemetil. And she's encouraged to report to a local ER for evaluation. And this is hard to read maybe, but this is what happens locally at a local.
It's fast.
Yeah. So AFib with RVR, does everyone agree with that?
Yep.
It definitely could be AFib, looks slightly irregular, but it could also be atrial tachycardia. It's just hard to see.
Okay, yeah, I know, it's not a very good.
Agree.
So she's diagnosed, the diagnosis is AFib with RVR. You can see there her biomarkers, and she's diagnosed with acute heart failure. She has a CTP protocol, which was negative, admitted to ICU, and this is what she is treated with. She's also quite hypotensive.
So do you know what drug she was actually getting, or was she in a randomized study?
She would have been, I think she was getting both of those drugs because this was a phase 2 protocol, I believe. So she was on the combination. Does that help?
Okay.
Yeah, I don't know if Dan's going to go on, and I know that I assume that the reason that you're presenting this case is for the potential osimertinib toxicity with the HER2 antagonism. Although also interesting that the person presented an acute heart failure and was given a diltiazem drip, which if done before the echo and stuff may have worsened the systolic function.
Yeah, now remember, all of this was done at a local hospital outside of Duke, I believe. It's my understanding.
None of it's Duke's fault, I get it.
Oh, no comment. But we do.
No, I think unfortunately that same process happens at WashU every day, where somebody comes into the emergency room with AFib with rapid ventricular response, and they get IV diltiazem just out of the box. They don't even think about anything else. And frequently we have to pick up the pieces from that at some later time. So yeah, I mean, this happens anywhere.
It does, Dan. And, you know, I had a patient, a breast cancer patient who was clearly septic. And when she presented to a local emerge and she was hypertensive and they put her on a diltiazem drip. Can you believe that? She was septic. I didn't know that. By the time she got here, she had almost no blood pressure. It was just crazy. I mean, why? Anyways, you know, so it is what it is. So she had a TTE, which showed an EF of 30% and severe MR. And she was there at this local hospital, I guess, for about a week. Continued to have AFib with RVR, and was then transferred to Duke, is my understanding at that point. And you can see her vitals at the bottom there. So she's still quite hypotensive, still not rate controlled, 130 to 140. Here's her ECG after transfer. Comments?
Definitely AFib there,
Yeah,
and still, you know, rapid ventricular response.
right. Still after a week. So here is, I believe, what she had done here. So she was known to have severe LV dysfunction, moderate MR, still AFib with RVR. And actually, she did undergo cardioversion here, which was successful.
Susan,
Yes.
that EF of 30% presumably was done on an echo with AFib at a rapid rate, or as you showing in the echo image, control?
Yeah, I think it was done. I think it was done at this rate, right? So she was still going,
Fast.
you know, yeah, the 120 to. So you want to? That's a good comment. You want to make a comment on doing echoes when people are.
Yes, I can't.
Excuse me.
I can't stand it when people. They're in such a hurry to order an echo that they don't take the time to control the ventricular rate first, knowing full well that there is, you know, because of the varying RR interval, it becomes very difficult not only to evaluate wall motion abnormalities, but to get a good sense of what the ejection fraction is. So we frequently, you know, conclude that, yes, the EF appears 30%, but taken with a grain of salt until the heart rate is better controlled, and then repeat the echo at that time.
That's a very good point.
Yeah. Excuse me.
Yes.
Yes, I'll be more blunt.
What is the yes? What was the size of left atrium? Is it normal or enlarged?
You know what? Sorry, I don't have. I guess I don't have that.
Yeah, but you have a comment there on the TEE. So I don't think we have to expect Susan to be able to defend the crazy cardiac decisions that were made in this case. But so what, Joe, you were going to say something?
I was just going to concur. I mean, I was going to be more blunt and say that getting an echo with RVR is just a waste of time and a waste of money. And it doesn't change anything you do.
Yeah.
Well, I mean, if you just look at the medical choices that were made on your previous slide, I mean, it's like, it's psychotic. So there's a bunch of psychotic decisions made right there. You know, digoxin, metoprolol, diltiazem, Lasix, apixaban, milrinone, phenylephrine. I mean, these people didn't apply any thought before doing something.
And again, I think you're right, Dan. I mean, this speaks to, I think that, you know, sometimes when people are out there in the smaller centers, they just get everything thrown at them with the hopes that something will work. At least that's my opinion.
The ER doctor with no specific cardiology training is just trying to stabilize the patient, keep them alive, and he's doing everything he can with whatever training he has.
Right, right. But, you know, so it is what it is.
I'm curious, Susan, you know, the two drugs that you had there, and Josh mentioned this a little bit.
I'm going to bring this right here.
Osimertinib is one thing, and, you know, certainly that is potentially relevant to your practice, even if you didn't fully realize that, since there is some thought that osimertinib inhibits HER2 in addition to HER1, which is EGFR1.
Right.
And there is, toxicity that's seen with osimertinib for LV dysfunction. So,
Right.
and, perhaps it's of a similar nature to Herceptin in that regard. But the thing that really bothered me is the other medication that you had there. Now, I have never heard of that medicine before.
This is it.
Yeah. And that right there, cardiomyopathy 23% of the time.
Right.
That's impressive.
That's impressive. So this is the study, right? So it was a phase 2 study. It is a phase 2 study. And here is a MEK1/2 inhibitor. And so you can see the toxicities up to 23% cardiomyopathy is pretty impressive in this context. So, and just to step back about this drug, Dan, which you so nicely brought up, just to let people know that this clearly has been shown to be beneficial in lung cancer patients with this mutation compared to traditional TKIs, with a pretty impressive improvement in median progression-free survival from 10 to 18.9 months. So this is certainly a drug on its own that has been shown to be beneficial. And these are the sort of side effects associated with this particular drug on its as a single agent. Rash we're used to, but you do see some prolongation of QT, as well as you can see a decrease in LVEF 4%, as stated there, cardiomyopathy 3%. So this drug on its own is perhaps not too bad. And this is also an interesting study that was published in JACC last year, where they actually went back and did a retrospective review of the FDA adverse event reporting system, and they queried terms such as cardiac failure, QT prolongation, AFib, and you can see the risk ratios of developing these cardiovascular events with this drug compared to other new drugs approved at a similar time in other TKIs, showing you that even with this drug, you do get an increased risk of QT prolongation, heart failure, and of course, AFib. And here are the risk ratios over here. So this drug does come with some issues. However, I think it's when you add it to this drug, obviously, as you pointed out, Dan, up to 23% risk of cardiomyopathy, and you're already adding it to a drug which places patients at risk of that.
Yeah, I mean, this is an extraordinary case, but yeah, I mean, I can't imagine. So you have a drug that if you just say, okay, osimertinib is very important for ALK positive lung cancer, and the outcomes are clearly better, like you showed on that slide. So there's a significant impetus to use osimertinib compared to erlotinib, which is the first generation.
Right.
But so there's a real reason to use it. It is very similar to what happened when trastuzumab came out, is that the cancer response was so impressive for trastuzumab that even though there was this high rate of toxicity, that everybody was like, well, we can't get rid of this drug because it's made such a big difference. And then we just have to figure out how to manage it better. So it took it took 10 years, 15 years to kind of refine how we deal with trastuzumab. I really think that osimertinib is going to be similar to that. I think the outcomes are so much better from a cancer point of view that you're going to accept a certain degree of toxicity to get the patient to stay on the drug or whatever, compared to what otherwise they would be treated with, which is really not effective at all. And so there's that. But then that new drug that you put on there, I mean, that's an impressive. There's I was looking up while you were presenting it, I was looking up the data on that drug. I mean, that sounds like a nasty drug. So then you're given two drugs in combination I don't know about that.
Oh.
That's,
Yeah, although I think that the rate of cardiomyopathy, even as impressive as it is, and this doesn't necessarily take away from anything, was for that combination, right? The cardiomyopathy of 23% was for the combination.
Yes, but still, yes, still
No, I'm
quite.
not.
Yeah.
Just for clarification, that we weren't adding that plus the osimertinib. That reflects both of them, and it is certainly impressive.
Yeah, no, good
Yeah,
point. Good.
I have a patient that I'm seeing right now that Dan actually saw too in the hospital, who had a spike drop in his EF, is having a terrible case of arrhythmias on osimertinib, and I asked his oncologist to potentially switch to erlotinib, but doesn't want to, given the benefit of osimertinib. So we're
Yeah,
dealing with a lot of arrhythmia
right?
issues.
Yeah, so that's why they don't want to switch, because of the significant, almost a doubling of the PFS compared to the traditional TKIs.
So I might be wrong, but I think in the last month there were 2 successive articles in the New England Journal about sulimetinib, and that the only cardiac toxicity that they actually listed was like a 10 or 15% incidence of atrial fib, but no hypertension and no cardiomyopathy in 2 different studies.
yeah,
So maybe that
well,
was a,
Joe, we would never admit that you were wrong. So I'm
No,
sure.
I might be wrong because maybe that wasn't the drug, and I
No,
can't get
I'm,
to the New
I'm
England
sure.
Journal right now to look at it.
Although it's possible that it's just the
Last month, I
combination
think
of the
that
two
it may be we're back.
Yeah, I mean,
sorry.
I think that, like Josh, like what you're saying is that I think it is the combination. So analogous to the combination of trastuzumab and anthracycline, where you saw a really substantial increase in cardiomyopathy. So I think that it is the combination, and the combination sounds pretty risky. So.
Yeah, so
So can I just
really big question with OSA,
yes?
with Tagrisso is the rechallenge business. I mean, I think that's the angst right now, because as Dan highlighted, I mean, it's so effective that
Right.
patients and oncologists want to re-challenge in the face of LV dysfunction. So I struggle all the time with this now.
So I can let you know what happened to this patient. So these are the medications they were on, but they were actually discontinued came off the trial and continued on single agent, as what we know has sort of become the standard of care. And then, 1 year later, their LVF had recovered to 50%. Their GLS was still a little bit down, but, improved, tolerating medical therapy, and was on lisinopril. That was increased, I guess, to 5 milligrams, not requiring Lasix. A statin was added. The CT scan of the chest showed, I don't know how enlarged the right upper lobe nodule was, but clearly the fact is that they're still alive and doing relatively well. 1 year out is good in terms of what they started with in terms of their prognosis for their cancer. So this, I thought, was a really interesting case because it sort of just goes to show you, really illustrating some of the additive toxicities when, again, we start adding these agents together to try and improve clinical outcomes. But sometimes sometimes those alleged clinical improvements in clinical outcomes come at a high cost. And so back to your comment, Dan, is that really, this is in case of phase 2 study, is the importance of really looking at the toxicity of these combinations. And I don't know the outcome of this, but it may be that this just is too toxic in the end to take it into clinical practice. Keeping in mind too that this is in the setting of a phase 2 study where you're picking the cream of the crop patients, and you don't pick those patients that aren't well enough to go on study. So that's the other thing to consider here as well.
Great. No, that's fantastic cases. Amazing. Thank you so much.
Yeah, so I think I'm not going to do the last case, which I think these first 2 were the most interesting anyways, just due to time. So thank you for everyone for bearing with me since, and for poor Jessica who made up these slides, and thank you for being so interactive in these cases. It was great discussion.
Yeah,
Thank you, Susan.
Great,
Thank
Susan.
you.
Okay, thank you, everybody.
all right, very good. Steve,
Okay.
are you still around?
Yes, sir. I just wanted to remind everybody that 1 week from today is our virtual Cardio-Oncology Summit. You still have time to register. Go to bcos2020.org. So no webinar next week, but same time next week will be our virtual summit.
Thank you.
Okay, thanks
Thank you.
everybody.
Thanks.
Thanks everybody for joining.
Excuse me.
Yes.
May I see the two slide before the in EKG in the case 2?
Yes.
Would you please go to case 2 and the two slide before the EKG?
Yeah, let me pull that up again. Sorry.
I'm so sorry.
No, that's okay. I have the cases here still.
I missed the slide. So sorry.
Let me just go there. Case 2. This
Case
one?
2, yes.
Mhm.
No, please go before this EKG. Okay.
This one here?
Yes, let me. I want to take a photograph if you let me. Yes, and the slide after that, would you please go?
This one?
No, after that, please go next slide. Yes,
I can
that
share
one. Yes,
slides.
thank you. Yes, this is slide. Yes, thank you very much.
Oh, you're
Thank
welcome.
you.
Okay. Bye-bye.
A very good case, fantastic, very good presentation, very good.
Okay, thank you. Okay, bye-bye.
Bye. Thanks.
Thanks all. Bye.